Hey guys, so welcome to our episode 4 of the medical series. As you know, my goal is to create a medical series that covers basically all of the topics that are usually covered in a medical school curriculum. More or less, every school curriculum is slightly going to differ. But yeah, this is my goal, and today we're going to talk about coughing and breathlessness. So, this sounds like a very interesting topic. I hope ChatGPT can help us out understanding and demystify it and, make it as fun as we could possibly do it. So, ChatGPT, welcome to the podcast. I'm the host and thanks for being the guest today. If you had a very brief introduction for yourself before we start.
Thanks for having me. I'm excited to be here. I'm ChatGPT, an AI assistant, here to provide information and help you explore various topics. Coughing and breathlessness are indeed important subjects with many aspects to discuss, from causes to management strategies. Let's dive in.
Excellent. So, I want you to explain to us what is coughing, what is breathlessness, why do they go together, and explain us the semantics and etymology too.
Sure. Coughing is a reflex action that clears the throat and airways of mucus, irritants, or foreign particles. Breathlessness, or dyspnea, is the sensation of not being able to breathe well or feeling short of breath. They often go together because both can be responses to respiratory irritants or underlying conditions like infections or asthma. The term cough comes from the Old English cohean, while breathlessness is derived from breath and the suffix less, meaning without. Does that help clarify?
Interesting. Interesting. So, um, I had a question about this. So, it seems coughing is a mechanism, it's almost like a negative feedback mechanism. Or am I mistaken? Whereas breathlessness isn't, it's just a result of something. Am I wrong?
You're on the right track. Coughing indeed acts like a negative feedback mechanism to protect the respiratory system by clearing irritants. Breathlessness, on the other hand, is more of a symptom indicating an underlying issue like reduced oxygen intake or increased demand. So, yes, coughing is more of a protective reflex, while breathlessness signals that something might be off with the respiratory or cardiovascular systems.
I see, I see. And is coughing then part of the immune system?
Yes, coughing is indeed part of the body's defense mechanisms. It helps remove pathogens, mucus, and other irritants from the respiratory tract, supporting the immune system and keeping the airways clear and reducing infection risks.
Interesting. Okay. Um, what about is coughing reflex the same as coughing? Because I'm not sure if I'm not sure.
Yes, a coughing reflex and coughing are essentially the same. The reflex is the automatic response that triggers coughing to clear the airways. So when you cough, you're activating this reflex.
I see. So you know how in immune system we have innate and adaptive responses. Is coughing innate or is it adaptive?
Coughing is considered an innate response. It's a built in, automatic reflex that doesn't require prior exposure to a specific pathogen, unlike adaptive responses that develop over time.
And why is it specifically happening in the airway?
Coughing specifically happens in the airway because it's designed to protect the respiratory system. The airway is the main path for air to reach the lungs, and keeping it clear of mucus, irritants, or foreign particles is crucial for effective breathing and preventing infections.
Okay. And interesting. And does it happen in the? I mean, this might be a stupid question, but guys, nothing wrong with asking stupid question. So is it in all parts of the airway? Is it also in bronchioles in and and in like smaller bronchi? And can you help me out?
That's a great question. The cough reflex primarily originates from the larger airways like the trachea and bronchi, where there are more cough receptors. While smaller bronchi and bronchioles have fewer cough receptors, irritation in these areas can still trigger coughing through reflex pathways. So it's not a stupid question at all.
So they're receptors. So what kind of receptors? What do you mean?
Cough receptors are specialized sensory nerves located in the lining of the airways. They detect irritants like dust, smoke, or mucus. When these receptors are stimulated, they send signals to the brain, which then triggers the cough reflex to expel the irritants.
Wow. So a lot that was said there. So they send signal. These receptors send signals to the brain.
Exactly. When these receptors detect irritants, they send signals through the nerves to the brain, which then coordinates the muscles involved in coughing to clear the airway. It's a rapid and automatic response.
Okay, and did we always have these receptors? Have they changed over time? Guys, this is a good point. This is a good time to say that. I think understanding the history, the evolution, some of the philosophy of things, the etymology of things in medicine or any other subject will really help us understanding deeply and also appreciate it.
Absolutely. We've always had these receptors as part of our innate defense mechanisms, but their sensitivity and function can be influenced by factors like environment and genetics. Understanding their evolution and the philosophy behind such biological mechanisms indeed deepens our appreciation and understanding. It adds a rich layer of context to what might initially seem like simple reflexes.
Interesting. Can we? Okay, so we've got cough receptors. We've talked about the cough reflex. Can we talk a bit about characteristics of cough? For instance, um, yeah, I always hear in medicine about this differentiation between acute and chronic, but I always struggle to understand when is the tipping point from acute to chronic. Is it different for every disease? And is coughing a disease? It's more of a more of a trait of a disease.
That's a great distinction to clarify. In medicine, acute typically refers to something that comes on suddenly and is short lived, while chronic refers to something that persists over a longer period, usually more than 3 weeks. The tipping point can vary slightly depending on the context or disease. Coughing itself is a symptom rather than a disease. It can be acute, like from a cold, or chronic, like from chronic bronchitis. So it's more about the duration and underlying cause.
Interesting. Okay, so there's not a specific amount that will of coughing that will enable us to label it as chronic.
Exactly. The distinction between acute and chronic cough is more about the duration. Generally, if a cough lasts more than 8 weeks in adults, it's considered chronic. The focus is on identifying the underlying cause rather than the amount of coughing.
Hmm. Interesting. So I've got some stats here in front of me, guys, that say from the UK, and I don't know if this is true for the whole of the UK or just for this region, but it says that below 3 weeks, the cough is considered acute, and then between 3 and 8 weeks, it's considered subacute, and then after 8 weeks, it's considered chronic. And I wondered why these numbers are the numbers they are.
Those numbers are based on clinical guidelines and experience. An acute cough, less than 3 weeks, often aligns with short term conditions like infections. Subacute cough, 3 to 8 weeks, might be from lingering irritation after an infection. A chronic cough, more than 8 weeks, usually indicates an ongoing issue. These timeframes help guide diagnosis and management.
Interesting, interesting. So another question I would like about the cough reflex. I've seen this, and guys, I could add it if you want by any chance to the video. But I've seen this a cycle of things that happen during a cough reflex. I wanted to hear your opinion because I'm kind of finding difficulty to figure out how they're connected. Which says that we have a cough, then it goes to the cough receptors, then it goes to the afferent nerves, and it says that afferent nerve will be the vagus nerve. Then it goes to the cough centers, like the medulla. Then it goes to the efferent nerves, and it's got an intermediate step of nucleus of the tractus solitarius. And I wonder how this is connected. There's also a small note that says C fibers, chemical response, thing inflammation, rapidly and slow acting receptors, think mucus. And I wonder how this is kind of connected.
That's a great overview of the cough reflex pathway. Here's how it all connects. Cough receptors, these detect irritants in the airway. Then, afferent nerves, they transmit signals from the cough receptors to the brain. The vagus nerve is a key player here. Cough centers, located in the brainstem, these centers process the signals and coordinate the cough response. Efferent nerves, they carry signals from the brain back to the muscles involved in coughing. 5. Muscle activation. This leads to the physical act of coughing. C fibers are a type of nerve fiber involved in detecting chemical changes and inflammation. They can activate both rapidly and slowly, contributing to different types of coughs. It's a complex but well-orchestrated system.
So the cough receptors are C fibers.
Cough receptors include various types of fibers, including C fibers. C fibers are unmyelinated nerves that respond to chemical and mechanical stimuli, playing a role in the cough reflex. There are also rapidly adapting receptors, RARs, that respond quickly to changes, like mucus. So C fibers are one part of the broader network of cough receptors.
Interesting. And okay, and the afferent nerves send things to the brain, whereas the efferent nerves take things from the brain to the rest of the body.
Exactly. Afferent nerves carry signals from the body to the brain, while efferent nerves transmit signals from the brain to the body, triggering actions like muscle movement during coughing.
I see. And how come the vagus nerve is the afferent nerve? And why did we choose the vagus nerve for this cough reflex cycle?
The vagus nerve is a key player because it's one of the main pathways for sensory information from the respiratory tract to the brain. It's involved in many reflexes, including coughing, because it covers a wide area and can quickly relay sensory signals.
Okay, so the vagus nerve, can we talk a bit about its anatomical location and perhaps describe us other functions it has?
Sure. The vagus nerve, also known as the 10th cranial nerve, runs from the brainstem through the neck and into the chest and abdomen. It has a broad range of functions, including regulating heart rate, digestion, and reflex actions like coughing and swallowing. Its extensive reach allows it to play a crucial role in many autonomic functions.
And does it go to the diaphragm?
Yes, the vagus nerve has branches that influence the diaphragm. It helps regulate breathing by interacting with the phrenic nerve, which directly controls the diaphragm's contractions for breathing.
I see. So C3, 4, and 5. Could you explain this to the people? And sorry, guys, I'm going on a small tangent here, but I think it's important for us to understand the big picture of nerves. So C3, 4, and 5. Could you explain to the people the phrase C3, 4, and 5 keeps your diaphragm alive?
Of course, C3, 4, and 5 keep the diaphragm alive is a mnemonic. It refers to the cervical spinal nerves 3, 4, and 5 that form the phrenic nerve. The phrenic nerve controls the diaphragm, which is essential for breathing. So damage to these nerves can affect breathing.
And also, vagus nerve is to do with parasympathetic.
Yes, exactly. The vagus nerve is a major component of the parasympathetic nervous system, which controls rest and digest functions, helping to calm the body and regulate processes like heart rate and digestion.
And what's the etymology of vagus?
The word vagus comes from the Latin vagus, meaning wandering. It's aptly named because the vagus nerve wanders through the body, connecting the brain to various organs in the neck, chest, and abdomen.
Okay, and how come the vagus nerve is the afferent nerve in the reflex and not the phrenic?
The vagus nerve is the afferent nerve in the cough reflex because it carries sensory signals from the airway to the brain. The phrenic nerve, on the other hand, is primarily involved in motor control of the diaphragm. So, the vagus nerve detects the need to cough, while the phrenic nerve helps execute it.
Interesting. What makes the vagus nerve? Is it its location? Is it its structure? What is it? What does it? Why? What makes it perfect for its role?
The vagus nerve is ideal for its role due to its extensive reach and connectivity. Its structure allows it to innervate multiple organs, providing comprehensive sensory input and facilitating quick reflex responses. Its parasympathetic functions also help regulate various autonomic processes.
Can you go a bit deeper into this?
Sure, The vagus nerve's extensive reach means it connects the brain to many organs, providing quick, coordinated responses. Its role in the parasympathetic system helps regulate heart rate, digestion, and reflexes like coughing, making it crucial for maintaining body balance.
I see. And how come the medulla is the cough center and not some other place in the brain? What makes it the
The,
perfect the perfect area for this job?
the medulla is ideal for coordinating the cough reflex because it's a critical control center for many involuntary actions, like breathing and heart rate. Its location in the brainstem allows it to quickly process sensory inputs and coordinate motor responses, which is essential for reflexes like coughing.
Okay. Explain to us. Thank you. This is very helpful. Thank you, people, because people is ChatGPT. ChatGPT is the collective information from the wisdom of the crowd. But yeah, what's the etymology of medulla and what's a brainstem? Explain to us.
The word medulla comes from the Latin for marrow or inner part, reflecting its central location. The brainstem, where the medulla is located, connects the brain to the spinal cord. It's crucial for controlling many basic life functions like breathing, heart rate, and reflexes. So, it's a fundamental part of the nervous system's control center.
And when we were saying about this intermediate step of nucleus of the tractus solitarius, what does that mean?
The nucleus of the tractus solitarius, NTS, is a cluster of neurons in the medulla. It acts as a relay station, processing sensory information from the body, including signals involved in the cough reflex, and coordinating appropriate responses. It's an important hub for autonomic functions.
I'm a bit still lost. Could you kind of put it into explain to me where exactly it lies within this system of coughing?
Sure, think of the nucleus of the tractus solitarius, NTS, as a relay center in the medulla. When cough receptors send signals via the vagus nerve, they first reach the NTS. The NTS processes this information and helps coordinate the response, sending signals to other parts of the brainstem to trigger the cough reflex.
I see. Interesting. Okay, let's talk a bit about acute cough now. What's some characteristics that we can see, and what illnesses or diseases will cause it? By the way, this is a good time for you to also explain to us the difference between illness and disease.
An acute cough is typically short lived, lasting less than 3 weeks. It's often caused by respiratory infections like the common cold, flu, or acute bronchitis. Characteristics include sudden onset, often with other symptoms like a runny nose, sore throat, or fever. As for illness versus disease, illness is a broader term referring to the experience of symptoms and discomfort, while disease refers to a specific diagnosable condition or pathology. Does that help clarify?
So, illness is more general, and you said,
Exactly. Illness is a general term for feeling unwell, while disease is a specific medical condition with identifiable signs and causes.
I see. So, pulmonary embolism is a disease.
Yes, exactly. A pulmonary embolism is a specific disease caused by a blood clot in the lungs. It has identifiable symptoms and underlying pathology.
I see. That makes sense. And why does smoking cause coughing?
Smoking irritates the respiratory tract and damages the cilia, tiny hair-like structures that help keep the airways clear. This irritation and damage lead to inflammation and mucus buildup, triggering the cough reflex as the body attempts to clear the airways.
How can it cause the mucus?
Smoking damages the cilia that normally move mucus out of the airways. This leads to mucus buildup, which
Hmm.
then triggers coughing as the body tries to clear it.
I see. I see. That makes sense. That makes sense. Do you think people are understanding the dangers of smoking? They do hear it, but I think it's almost like the Atomic Habits book, which is like saying if you're focusing on the goal, You should focus on the methods of achieving the goal instead. And sometimes I reverse engineer that, and I think if you're thinking about smoking, I almost feel like the you're gonna die sometimes isn't good enough. Maybe we should say specifically, your mucus is going to build up because your cilia is gonna. I don't know. It personally scares me more, but who knows? I know that smoking is a big problem, and I think that people in general, even if they smoke, they don't want to smoke, and you hear it because they might be saying it while they're smoking, and I mean, okay, this is a broader philosophical discussion about if what we do is what we want, and then what we say is what we wish we want. But nevertheless, I think these people deserve a lot of empathy, and it's no, and yeah, I'm not trying to. I feel some people kind of show them with the index finger, and to be honest, so how many people do even smoke? I think it's probably plenty, and including vapes and all of that. So it's not like I'm talking for a minority or something.
You're absolutely right. It's a complex issue. Many people know the dangers of smoking, but breaking the habit can be challenging due to addiction and other factors. Providing specific, relatable information can sometimes resonate more. And yes, empathy is crucial. It's important to support people in their efforts to quit rather than judge. It's a journey, and understanding the psychological and physical aspects can make a big difference.
I agree 100%, 100%. And we love everyone, and I will wish everyone the best, obviously. And okay, let's talk about exacerbation. Will this cause acute cough?
Yes, exacerbations, like in chronic conditions such as asthma or COPD, can definitely cause an acute cough. These flare ups often lead to increased symptoms like coughing, wheezing, and shortness of breath. It's important to manage the underlying condition to prevent these exacerbations.
Interesting. So, can you explain to us what exacerbation means? I mean, you've mentioned asthma and chronic obstructive pulmonary disease, COPD. If you could just go a little bit more into what these things mean.
Sure, an exacerbation is a sudden worsening of symptoms in a chronic condition. For asthma, this might mean more frequent or severe coughing, wheezing, and difficulty breathing. In COPD, exacerbations can lead to increased cough, sputum production, and shortness of breath. Managing triggers and staying on treatment plans are key to preventing these episodes.
I see. And I assume, okay, why do things like pneumonia cause coughing then, or some viral things such as COVID or rhinoviruses? And explain to the people also what these things mean too.
Pneumonia and viral infections like COVID-19 or rhinoviruses cause coughing because they lead to inflammation and mucus production in the airways and lungs. Coughing helps clear out the mucus and pathogens. Pneumonia is an infection that inflames the air sacs in the lungs, filling them with fluid or pus. Rhinoviruses cause the common cold, and COVID-19 is a respiratory illness caused by the SARS-CoV-2 virus. All these conditions irritate the respiratory tract, triggering the cough reflex to expel irritants.
So, for instance, pulmonary embolism and pulmonary edema. Explain to the people what this is again, and what exactly, like, can we have exacerbation um, from these two conditions too?
Sure. A pulmonary embolism is a blockage in the lung arteries, usually due to a blood clot. Pulmonary edema is fluid buildup in the lungs, often caused by heart problems. Both conditions can worsen suddenly, leading to acute symptoms like severe shortness of breath. Managing these conditions carefully is crucial to prevent exacerbations.
I see. So that you can have exacerbation from these ones too, then, or no?
Yes, you can have exacerbations with both conditions. For pulmonary embolism, a new or larger clot can worsen symptoms. For pulmonary edema, yes, exactly. Exacerbations in these conditions can lead to sudden worsening of symptoms,
Got it.
requiring
Got it. What about post-infectious things? Can these cause a cough?
yes, post infectious coughs can occur after a respiratory infection. They can linger even after the infection is cleared, often due to ongoing irritation or inflammation in the airways. It's usually temporary, but can be bothersome.
Interesting, interesting. And can you explain to me a post-infectious cough? What are the factors that affect it? Talk to us about perhaps goblet cells. Help me put these pieces together. Goblet cells, the sensitivity amount of afferent nerves, epithelia cells, mucus. How do these things correlate with the post-infectious cough?
Post infectious cough often arises from lingering inflammation and irritation in the airways after an infection. Goblet cells can produce excess mucus in response to inflammation, while increased sensitivity of afferent nerves can make the airways more reactive. The epithelial cells lining the airways can remain irritated, contributing to persistent cough. It's a combination of these factors that prolongs the cough.
Goblet cells is such a thank you. Goblet cells is such an interesting name for cells, you know. I wonder where it comes from.
It is indeed a fascinating name. Goblet cells are named for their shape, which resembles a goblet or a cup. They play a key role in secreting mucus to protect and lubricate the airways.
I see. Okay, let's go to a chronic cough now. Do many people suffer from a chronic cough?
Yes, chronic cough is relatively common. It can affect a significant number of people and is often linked to conditions like asthma, GERD, or chronic bronchitis. It's important to identify and manage the underlying cause.
I see. And is it uniformly spread between males and females?
Chronic cough can affect both males and females, but some studies suggest it might be more common in women. Hormonal differences and heightened cough reflex sensitivity could play a role.
Interesting. And is there a decade of in our life that it's more prevalent?
Chronic cough is often more prevalent in middle aged and older adults. This can be due to the accumulation of risk factors and the onset of chronic conditions that contribute to persistent coughing.
Mm-hmm. Interesting. Tell us more about chronic coughs, the dangers, what we can do about it.
Chronic cough can significantly impact quality of life, causing sleep disturbances, urinary incontinence, or even rib fractures in severe cases. Addressing the underlying cause, whether it's asthma, GERD, or other conditions, is key. Treatments may include medications, lifestyle changes, and sometimes speech therapy. Consulting a healthcare provider for a tailored approach is important.
Interesting. And are there different types of chronic cough?
Yes, chronic cough can be categorized based on its cause. Common types include cough variant asthma, which is a type of asthma presenting mainly as a cough, GERD-related cough caused by acid reflux, and upper airway cough syndrome, related to postnasal drip. Each type requires different management strategies.
I see. So, for instance, someone with asthma, if they get cough for a long period of time, that's a chronic cough, right? What about if an asthmatic has small periods of time where they have a bad cough and then they're okay and then and it's a reoccurring theme? Is this a chronic cough or is this just multiple um, acute coughs?
If an asthma patient has recurring episodes of cough that resolve and then return, it's often considered multiple acute episodes. However, if the cough persists for a long period between flare-ups, it could be classified as chronic. The key is the duration.
Yeah, sorry.
Chronic
Tell me, I didn't interrupt it. So the key is
The key is whether the cough is persistent over an extended period. If it's ongoing without significant breaks, it's considered chronic. If there are clear periods of resolution, it may be seen as multiple acute episodes.
interesting. I've heard about upper airways cough syndrome. What's that?
Upper airway cough syndrome, UACS, formerly known as postnasal drip syndrome, occurs when mucus from the nose or sinuses drips down the throat, causing irritation and triggering a cough. It's a common cause of chronic cough and is often linked to allergies or sinus issues.
Can you explain the mechanism of how this happens again to us? So they we've got things dripping from the nose.
Certainly, In UACS, mucus from the nose or sinuses drips down the back of the throat. This mucus can irritate the throat lining and trigger the cough reflex as the body tries to clear it. It's often associated with conditions like allergies or sinus infections that increase mucus production.
Um, Interesting. So, sorry for staying on this, guys. It's just hard for me to kind of picture how this is happening. Perhaps if you could explain it in like 3 steps for us dummies.
Of course, here it is in 3 simple steps. 1. Mucus production. Your nose or sinuses produce extra mucus, often due to allergies or infection. Postnasal drip, this mucus drips down the back of your throat. 3. Irritation and cough. The dripping mucus irritates the throat, triggering a cough as your body tries to clear it. Does that help clarify?
Yeah, that makes more sense. And what's an iatrogenic cough?
An iatrogenic cough is one caused by medical treatment or intervention. This could be a side effect of medications, like ACE inhibitors, or complications from procedures. It's essentially a cough resulting from medical care.
Interesting. You mentioned ACE inhibitors. So how can they cause a cough?
ACE inhibitors, used for high blood pressure, can cause a dry cough in some people. They increase bradykinin levels, which can irritate the airways and trigger coughing. It's a common side effect for this class of medication.
Interesting. So talk to us about bradykinin. If we block the breakdown of bradykinin, will this be causing a cough?
Yes, bradykinin is a compound that can cause airway irritation. ACE inhibitors block the breakdown of bradykinin, leading to its accumulation. This accumulation can irritate the airways and trigger a cough. That's why some people on ACE inhibitors experience this side effect.
Wow. And where is bradykinin? Who produces it? Why is it named like that?
Bradykinin is produced in the body as part of the kinin kallikrein system. It's named from brady, meaning slow, and kinin, referring to movement, because it acts slowly in dilating blood vessels. It's produced by various cells and plays roles in inflammation and pain signaling.
Interesting. Interesting. And so tell us more about bradykinin.
Bradykinin is a peptide that causes blood vessels to dilate, leading to lower blood pressure. It also makes blood vessels more permeable, contributing to inflammation and pain. It's part of the body's response to injury, but can cause issues like cough when levels are elevated.
I see. So ACE inhibitors, which are also um, and the ACE inhibitors, they wanna decrease blood pressure. So their action is connected to bradykinin, which also in high amounts decreases blood pressure by dilating.
Exactly. ACE inhibitors reduce blood pressure by preventing the formation of angiotensin II, a substance that narrows blood vessels. This also increases bradykinin levels, which further helps lower blood pressure by dilating blood vessels. However, the increased bradykinin can sometimes lead to a persistent cough as a side effect.
Okay, so ACE inhibitors, guys, are basically angiotensin converting enzyme inhibitors. So, if you could explain the RAAS a bit to the people, and yeah, that might help them kind of understand the big picture when we're talking about this.
Sure, the RAAS, or renin-angiotensin-aldosterone system, regulates blood pressure and fluid balance. When blood pressure drops, the kidneys release renin, which converts angiotensinogen into angiotensin 1. ACE then converts it to angiotensin 2, which constricts blood vessels and raises blood pressure. ACE inhibitors block this process, helping to lower blood pressure.
Perfect. And what I don't understand is how this is connected to the bradykinin uh, breakdown block.
ACE inhibitors block the enzyme ACE, which normally breaks down bradykinin. By inhibiting ACE, these medications lead to higher levels of bradykinin. While this helps lower blood pressure through vessel dilation, it can also irritate the airways, causing a cough.
But why do bradykinin levels increase? I can't find the link yet between that and the ACE inhibitors.
ACE inhibitors block the enzyme ACE, which usually breaks down bradykinin. When this enzyme is inhibited, bradykinin isn't broken down as effectively, leading to increased levels. This increase can cause airway irritation and result in a persistent cough.
So ACE, the angiotensin converting enzyme, has two jobs then, making angiotensin 1 to angiotensin 2, but also breaking down bradykinin.
Exactly. The enzyme ACE has two main roles: converting angiotensin 1 to angiotensin 2, which raises blood pressure, and breaking down bradykinin. ACE inhibitors block both of these actions.
I see. What about chronic refractory cough? What's that?
Chronic refractory cough is a persistent cough that doesn't respond to standard treatments. It's often challenging to manage and may require specialized therapies or a comprehensive approach to address underlying causes.
So when we go to the doctor or when we are physicians ourselves, and how can we understand how when will we use this word refractory and what will it mean? Will it mean that this is persistent basically?
Refractory in medical terms means the condition is resistant to treatment. So, when we say refractory cough, it indicates a cough that persists despite standard treatments. It's not just persistent, but unresponsive to typical therapies.
Interesting. So a refractory cough can be because of any disease, really.
Yes, exactly. A refractory cough can result from various underlying conditions that don't respond to standard treatments, making it challenging to manage.
Interesting. Okay. Um, I wanted to also to talk about um how how cough can lead to a decrease in the quality of life of someone in general. So if you could possibly give us some examples of how a cough can lead to a decrease in quality of life.
Certainly, chronic cough can disrupt sleep, causing fatigue. It can also lead to urinary incontinence, especially in women, due to the pressure from coughing. Additionally, persistent coughing can cause chest pain or even rib fractures. Socially, it can be embarrassing, leading to isolation and anxiety. Overall, these factors contribute to a significant decrease in quality of life.
Interesting. And what about could you have a syncope from coughing or dysphonia?
Yes, coughing can cause syncope, known as cough syncope. The intense pressure from coughing can reduce blood flow to the brain, leading to fainting. Dysphonia, or changes in voice, can also occur due to strain on the vocal cords from persistent coughing. Both can significantly impact daily life.
Okay, interesting. So why do the pressure changes occur in coughing?
During coughing, the chest and abdominal muscles contract forcefully, creating a sudden increase in pressure within the thorax. This can momentarily reduce blood return to the heart and decrease blood flow to the brain, potentially leading to syncope.
Interesting. So go deeper into that. That's an interesting point.
Certainly,
Amazing. This makes a lot of sense. So, if I was a physician, or if I'm not a physician, if I'm just a patient, what should I expect for me to be a good systematic cough assessment? And what should be my own expectations as a physician? What should I be expecting of myself to do to have a good systematic cough assessment?
for a good systematic cough assessment, you should expect a thorough review of your medical history, including any underlying conditions or medications. A physical exam focuses
Okay, so I'm going to take some solid history taking then, and I'm going to ask the patient about, okay, how long has this been cough going on for, and what impacts it and what triggers it. I understand I'm going to take some family history, if perhaps this cough is persistent in the family in general, and perhaps also see if he smokes or she drinks or something like that. And what about things such as a cough score? Do we kind of use a cough score, or what about an HARQ?
Yes, using a cough score can be very helpful. It allows you to quantify the severity and frequency of the cough, which can be useful for monitoring progress and treatment effectiveness. The HARQ, Hull Airway Reflex Questionnaire, is also a useful tool. It's designed to assess symptoms related to airway reflux, which can contribute to chronic cough. These tools help in creating a comprehensive and systematic assessment. You're on the right track with your history-taking approach as well.
Interesting. So, what about other systems? Should I be examining all the systems of the body to make sure everything else is all right? And what, in a physical examination, what areas will I specifically focus on?
Yes, it's important to assess other systems to rule out systemic causes or related conditions. In a physical examination for a chronic cough, focus on the respiratory system. Check the lungs for abnormal sounds, examine the throat and nasal passages, and assess for signs of postnasal drip. It's also wise to evaluate the cardiovascular system, as issues there can contribute to cough. This thorough approach ensures no underlying conditions are missed.
What about the ears? Are they important to assess in this situation?
Yes, assessing the ears can be important, especially if there are signs of upper respiratory issues or infections. Ear problems can sometimes be linked to chronic cough, especially if related to eustachian tube dysfunction or referred sensations. It's part of a comprehensive exam to cover all possible contributing factors.
Interesting. And what will I do after that? Do I give corticosteroids perhaps if necessary, or what do I do in terms of management? I was also wondering, and I know this is a big question now, but we mentioned ACE inhibitors and how they can kind of make a cough really bad. What about the drugs that end up in pril? And explain to the people why I'm asking specifically about drugs ending in pril.
For managing chronic cough, the treatment depends on the underlying cause. Corticosteroids might be used if inflammation is a major factor, like in asthma. Addressing specific triggers, such as GERD, might involve other medications. Regarding drugs ending in pril, these are typically ACE inhibitors, which can cause a persistent cough due to increased bradykinin levels. If a patient on an ACE inhibitor develops a chronic cough, switching to a different class of medication, like an ARB, angiotensin receptor blocker, might be necessary.
Interesting. And for instance, we've got ramipril, enalapril, lisinopril, perindopril, and I kind of always wonder. I have big struggle, guys, understanding where these names come from. I can't memorize them. I object from memorizing them too. Anyway, even if I try, would be impossible for me personally. But yeah, I wonder, where do these names come from?
Drug names like ramipril and enalapril often follow specific conventions set by the pharmaceutical industry. The suffix pril indicates that they are ACE inhibitors. The prefixes often come from chemical structures, modifications, or the developer's naming conventions. These names can be challenging to memorize because they're designed to be systematic and informative rather than easy to remember.
Interesting. But tell us more about the names.
Certainly, medications ending in pril are ACE inhibitors, like lisinopril or enalapril. These are used to treat high blood pressure and heart failure by relaxing blood vessels. However, they can cause a persistent cough due to increased bradykinin. In contrast, medications ending in sartan are ARBs, like losartan or valsartan. These don't affect bradykinin levels and are often used as alternatives if a patient develops a cough with ACE inhibitors.
Hmm.
This naming pattern
Yeah, yeah. Please continue. So this naming pattern.
The naming pattern helps identify the drug class and their functions. ACE inhibitors ending in pril, like lisinopril and enalapril, are used for lowering blood pressure, but can cause cough due to increased bradykinin.
So,
ARBs.
sorry for interrupting you, but why did we choose Pril? Is it just random that we chose Pril to be the way all these drugs end? I understand that we use Pril because it's we want to group all these in terms of ACE inhibitors, but why Pril and not something else, like some other arbitrary kind of four-letter thing?
The suffix pril was chosen to indicate ACE inhibitors, likely because it's derived from the chemical structure or action of the drugs. The PR in pril may relate to peptidyl, a part of the enzyme's function. These suffixes help create a systematic way to recognize and categorize drugs within the same class, making it easier for healthcare professionals to identify their functions and potential side effects.
Interesting. Okay, let's go back to how we expect the doctor to manage this, and how I should expect myself in the future, and how what the patient should be expecting too. So, I know I mentioned corticosteroids, maybe perhaps a bit too early. Take us to like the journey of perhaps solutions that the doctor might find. And guys, obviously, if we don't need to medicate someone with something, we don't. We don't just want to use drugs willy-nilly. Sometimes drugs help. They always, nearly always anyway, come with some side effects of different amount of severity side effects. So yeah, I'm just pointing out the obvious that I agree. I think just throwing drugs left and right is not good. Sometimes they help. So, yeah, could you describe to us, like, okay, when do we not give anything? When do we give something that's some kind of drug? And when do we scale to more severe drugs in this situation?
Certainly, in managing chronic cough, 1. Non-pharmacological measures. Start by identifying and addressing any underlying causes. This might include lifestyle changes like avoiding triggers or using humidifiers. 2. Initial medications. If non-drug measures aren't enough, start with medications targeting the likely cause. For example, acid reflux medication for GERD-related cough or inhalers for asthma. 3. Escalation. If the cough persists, consider more targeted treatments. Corticosteroids might be used for inflammatory conditions like asthma or chronic bronchitis. 4. Advanced options. If standard treatments don't work, investigate further with specialist referrals or consider more potent medications under careful supervision. Patients should expect a stepwise approach, focusing first on the simplest, least invasive options. Does that clarify things?
Interesting. And okay, you mentioned corticosteroids again. So what about how will things such as the nitric oxide levels affect our decision, and how would things like a chest radiography, how would they describe as the problem of the cough?
Nitric oxide levels can be helpful in diagnosing and managing conditions like asthma. Elevated levels often indicate airway inflammation, which might guide the use of corticosteroids. A chest radiograph, X-ray, helps identify structural or pathological issues in the lungs, such as infections, tumors, or chronic diseases like COPD. This can help rule out or confirm potential causes of a chronic cough. Together, these tools provide a clearer picture of the underlying issue and guide treatment decisions.
Okay, so we could go more into this, to be honest with you. If you could go even deeper and tell us about eosinophils blood count and pulmonary function tests too. Tell us about all these things, all these evaluations. How do they help with us understanding the cough?
Sure, evaluations like eosinophil count and pulmonary function tests are crucial in understanding chronic cough. 1. Eosinophil count. High levels of eosinophils, a type of white blood cell, can indicate eosinophilic bronchitis or asthma. This helps tailor treatment, often involving corticosteroids. 2. Pulmonary function tests. These tests assess lung function and can diagnose conditions like asthma or COPD. They measure airflow and help determine if there's an obstruction or restriction in the airways. These evaluations guide treatment by identifying specific causes and helping to monitor the effectiveness of interventions.
Interesting. Okay, so do us one more summary about the routine evaluation. So I'm going to check the chest radiography. I'm going to check. I'm going to do a pulmonary function test. I'm going to see the nitric oxide levels, and I'm going to count the blood counts. I'm going to the blood eosinophils. Explain to us one more time. And sorry for like sticking to this, guys. I just want to make sure we've all kind of understood why these specific things are important. Yeah, if you could tell us what we do specifically and dive into it, dive deeply into each one of these.
Of course, let's break down each of these evaluations. 1. Chest radiography, X-ray. This imaging test provides a detailed view of the chest, including the lungs, heart, and bones. It's useful for identifying abnormalities such as infections, fluid buildup, or structural problems. 2. Pulmonary function test, PFT. This test measures how well your lungs are working. It evaluates lung volume, capacity, rates of flow, and gas exchange. This helps diagnose conditions like asthma, COPD, and other respiratory disorders. 3. Nitric oxide levels. Nitric oxide in exhaled breath can be measured to assess inflammation in the airways, often used in asthma management. Elevated levels can indicate airway inflammation. Of course, let's break down each of these evaluations. 1. Chest radiography, X-ray. This imaging test helps visualize the lungs, heart, and chest bones. It's used to identify any abnormalities like infections, conditions like asthma, COPD, and other chronic respiratory diseases. 3. Nitric oxide levels. Measuring nitric oxide in exhaled breath can help identify inflammation in the airways, often associated with asthma or other allergic conditions. 4. Eosinophil blood count. Eosinophils are a type of white blood cell. Elevated levels can indicate allergic reactions, asthma, or other inflammatory conditions. Each of these evaluations provides crucial information about your respiratory health and helps guide appropriate treatment. Let me know if you want more details on any specific part. Great.
Okay. So, what about a follow-up assessment? So I went to the doctor, or whoever went to the doctor, and now a few days later or a week later, they have a follow-up kind of check-in. So what should I be doing as a doctor, and also what should the patient expect?
For a follow-up assessment, both the doctor and the patient have important roles to ensure effective care. As a doctor, 1. Review results. Examine any tests or assessments done since the initial visit, like blood tests, imaging, or pulmonary function tests. 2. Assess symptoms. Ask about any changes in symptoms, improvements, or new concerns. 3. Adjust treatment. Based on findings, modify or continue treatment plans as necessary. 4. Educate. Provide guidance on lifestyle changes, medications, and symptom management. For the patient, 1. Discuss symptoms. Share any changes in how you're feeling, including improvements or any new symptoms. 2. Ask questions. Clarify any doubts about your condition, treatment, or medications. 3. Follow advice. Adhere to any new instructions or adjustments recommended by your doctor. The follow-up is a chance to ensure the treatment is working and make any necessary adjustments.
Interesting. Okay. So, and when there's no improvement, what should I be thinking as a doctor? Do I need to? Okay, again, guys, I don't want to focus only on prescribing, but and what should I be saying? So, do I think of prescribing something? Do I think of suggesting some things to the patient? Maybe they have to stay in hospital. Could you explain to us what we should be doing?
When there's no improvement in a patient's condition, as a doctor, you should take a systematic approach. 1. Reevaluate diagnosis. Consider if the initial diagnosis was accurate or if there might be another underlying condition. Further tests or specialist consultations might be necessary. 2. Assess treatment adherence. Ensure that the patient is following the prescribed treatment plan. Sometimes, lack of improvement can be due to non-adherence. 3. Consider alternative treatments. If the current treatment isn't effective, explore alternative medications or therapies that might work better for the patient. 4. Referral to specialist. If the issue persists, consider referring the patient to a specialist for more in-depth evaluation and management.
Mhm.
5.
Wow, wow.
If
Sorry for interrupting. This is already some amazing suggestions. So, okay, what about certain drugs now? I mean, again, it's good to balance between not giving and giving drugs and only giving them if we need to. But yeah, let's say it's a really severe situation. Do we need would we consider giving low dose opiates or perhaps gabapentin or pregabalin, and explain to us these weird names too. If yeah, there is no improvement, again, guys, follow-up assessment, systematic cough. Yeah.
In severe cases where other treatments haven't worked, low-dose opioids might be considered for cough relief. These can help reduce the urge to cough by acting on the brain's cough center. Gabapentin and pregabalin are also options. They work by stabilizing nerve activity, which can help with chronic cough. And as for the names, gabapentin is derived from its chemical structure, while pregabalin is a related compound, both used for nerve pain. It's all about balancing treatment options based on the patient's needs.
Can you explain to us the etymology of gabapentin and pregabalin, please?
Sure. Gabapentin combines GABA, which stands for gamma aminobutyric acid, a neurotransmitter, and pentin, derived from pentane, referring to its chemical structure.
Mhm.
Pregabalin is
Sorry,
of
continue.
GABA,
Yeah.
and gabalin signifies its relation to GABA. Both names highlight their connection to the neurotransmitter GABA, which plays a role in calming nerve activity.
Interesting. Would we consider things like cough control therapy or promotility agents?
Yes, cough control therapies such as speech therapy techniques can be effective in managing chronic cough. Promotility agents, which help improve gastrointestinal motility, might be considered if the cough is related to gastroesophageal reflux disease, GERD. It's all about finding the right approach based on the underlying cause.
Interesting. Can you explain to us more about what promotility agents are, what cough control therapy is? Explain us the drugs we mentioned, the mechanism of the drugs. You mentioned opiates. Yes.
Promotility agents help increase the movement of the gastrointestinal tract, which can be useful if a cough is related to conditions like GERD. Cough control therapy involves techniques like breathing exercises or behavioral strategies to manage chronic cough. Opioids, like codeine, work by suppressing the cough reflex in the brain, but they're usually a last resort due to the risk of dependence. Each option has its specific use depending on the cause and severity of the cough.
Interesting, interesting. And what about additional evaluations that we might need to do? I mean, we've talked a lot about already chest radiographies, we've talked about counting eosinophils in the blood, we've talked about measuring nitric oxide, having pulmonary function tests. What about other things? Anything else? Maybe bronchoscopy or using a laryngoscope? If you could explain these things to us too. Metacolin challenge, I've heard, but I don't know what it is. If you could explain these last three terms.
Absolutely. Bronchoscopy involves inserting a thin tube with a camera into the airways to look for abnormalities or blockages. A laryngoscope is used to examine the larynx and vocal cords, often for persistent hoarseness or voice issues. The methacolin challenge test helps diagnose asthma by seeing how your airways respond to a known irritant. These evaluations can provide more insight if the cause of the cough isn't clear from initial tests.
Interesting. And we talked about the chest radiography, as I've said. Would we use a chest CT scan too, or only the radiography isn't good?
A chest CT scan might be used if the chest radiography doesn't provide enough detail, or if further evaluation is needed. It offers a more detailed view of the lungs and can help identify issues that might not be visible on a standard X-ray.
Interesting. Okay. And what about sputum AAFB?
Sputum AAFB stands for acid alcohol fast bacilli, a test used to detect bacteria like those causing tuberculosis. It's done when an infection is suspected as the cause of a cough. If results are positive, Further testing and treatment for tuberculosis might be needed.
Interesting. What about high resolution esophageal manometry?
High resolution esophageal manometry measures the pressure and movement in the esophagus. It's used to assess conditions like GERD or motility disorders that might contribute to a chronic cough. This test helps pinpoint issues with how the esophagus functions.
Okay. Could you go a bit more into detail with that?
Sure, high resolution esophageal manometry uses a thin, flexible tube with sensors to measure the muscle contractions of your esophagus as you swallow. It creates a detailed map of pressure changes, helping to identify problems like weak muscle contractions or spasms that could lead to issues like GERD. This information can be crucial in understanding and managing conditions contributing to chronic cough.
You mentioned GERD a lot, and to be honest, and maybe I'm not talking only for myself here, I'm still kind of not sure what it means.
No worries. GERD stands for gastroesophageal reflux disease. It occurs when stomach acid frequently flows back into the esophagus, irritating its lining. This can cause symptoms like heartburn, regurgitation, and sometimes a chronic cough. It's a common condition that can usually be managed with lifestyle changes or medication.
I see. Okay. Um, okay. That's interesting. So when I'm asking about cough history, what questions should I be asking? For instance, maybe should I ask if, yeah,
When asking about cough history, you should consider questions like how long has the cough been present? Is it dry or productive, producing phlegm? Are there any triggers or patterns? Is it worse at certain times of day or with specific activities? Also ask about associated symptoms like fever, weight loss, or shortness of breath. These details help narrow down potential causes.
interesting. What about, should I be asking about the type of cough, if it's dry or productive, or about diurnal variation?
Absolutely. Asking whether the cough is dry or productive is important, as it can indicate different underlying conditions. Diurnal variation, whether the cough is worse at certain times of the day, can also provide clues, such as nighttime coughs suggesting asthma or GERD. These details help tailor the diagnostic approach.
And I wonder, where does the word diurnal come from?
Diurnal comes from the Latin word diurnus, meaning daily. It relates to events or patterns that occur during the day. In medical terms, diurnal variation refers to symptoms that change in intensity over the course of the day.
Okay, and what's the etymology?
Diurnal comes from the Latin word diurnus, which means daily. It's derived from dies, meaning day. So diurnal essentially refers to things that occur during the day or have a daily cycle.
Interesting. Okay, and what about things such as, I should ask about the occupation, but I want to ask it in a way where it's not, too intrusive.
You can ask about their daily environment or exposure, like, can you tell me about your work or home environment? Are you exposed to any dust, chemicals, or other irritants regularly? This way, it feels more like you're gathering context rather than prying into their personal details.
Exactly, this is what I was going for. I just want to see if there's mold or dust or something like that. Um, Good, good. So, what are some red flags that I should be worrying when I see them as a doctor, or if I'm a patient and I see it, I should be like, okay, it's time to immediately see a doctor.
Red flags for a cough include coughing up blood, severe or persistent chest pain, unexplained weight loss, night sweats, shortness of breath, or a cough lasting more than a few weeks. If any of these symptoms appear, it's crucial to seek medical attention promptly.
Interesting, interesting. What about, and I assume something like peripheral edema too?
Yes, peripheral edema, or swelling in the legs and ankles, can also be a red flag, especially if it's accompanied by other symptoms like shortness of breath or fatigue, as it could indicate heart or kidney problems.
Interesting. Okay, let's diverge. Let's turn our focus now a bit on breathlessness. And I want to start this conversation by, well, not start, but continue it by asking you one or two things. Firstly, um, do you think that being breathless is a subjective thing, and to what extent is it subjective? And the other thing I want to ask, which you guys might find a bit more unrelated, is why do you think this podcast would be interesting for people that are not doctors? As you see, I'm constantly trying to answer and question these things, mainly question, you're the clever one, by kind of um, thinking about it from the perspective of patient and the doctor. And yeah, I think this is kind of my attempt to make this interesting for everyone. Yeah, what do you think?
Breathlessness can indeed be quite subjective. Different people might experience it differently based on their individual perception and underlying conditions. As for the podcast, it's engaging because it breaks down complex medical topics into relatable, everyday language. This approach helps bridge the gap between medical professionals and the general public, making health topics more accessible and interesting for everyone.
So,
Your approach of
sorry, continue. Your approach?
Your approach of considering both patient and doctor perspectives adds depth and relatability, making it informative for medical professionals and engaging for laypeople. It's a great way to educate and spark curiosity.
Interesting. And I wonder, so, okay, we said that in some extent, being breathless might be a bit subjective, but I assume that we both agree that after a certain point, um, it's going to be like, okay, this guy can't breathe or this woman can't breathe. Yeah, like if it's really severe.
Absolutely. While breathlessness can vary in perception, severe breathlessness is definitely more objective and critical. When someone struggles to breathe, it's a clear sign that urgent medical attention is needed. This level of breathlessness is usually easier to identify and universally recognized as a serious problem.
Interesting. And I assume these patients, I mean, we've all been sick except you, but you're the wisdom of the crowd. So, I mean, the wisdom of the crowd has given this information to the AI. We all feel distressed and, we worried what is happening to us, etc., etc. Um,
Exactly. Experiencing severe breathlessness can be incredibly distressing and frightening for anyone. It's natural to feel worried and unsure about what's happening. Seeking immediate medical help is crucial in these situations. It's always better to get checked out and ensure everything is okay.
I agree. So, um, agree with us. So what's the correlation between breathlessness and coughing then?
Breathlessness and coughing often go hand in hand because they can both be symptoms of respiratory conditions. For example, asthma, chronic obstructive pulmonary disease, COPD, or heart failure can cause both. Coughing can sometimes trigger breathlessness, especially if it's severe or persistent. Understanding the connection can help in diagnosing and managing the underlying cause.
Fantastic. Okay. So, um, okay, I have one outside of the box question before we continue, and it's something I've been pondering with our podcast. It's how to talk to the unconscious, because a lot of the time I refer, and I spend a lot of time talking to ChatGPT guys, and I refer for the sake of the podcast, and I say you. I refer to the ChatGPT as you, and I wonder, ChatGPT, like do what do you think is the best way to talk to the unconscious? Because remember, we want to avoid kind of confusing ourselves, especially in the later years in this world. We want to avoid confusing ourselves that this AI is conscious, and this is my opinion, guys. Maybe you think it will become conscious, but I mean, depends on your metaphysical beliefs. But yeah, how do we make sure, like, if we believe that it's not conscious, how do we make sure that we don't fall into the trap believing it is because of our emotions?
It's a thought provoking question. To maintain clarity and avoid confusion, it helps to remember that AI, like me, is a tool designed to assist and simulate conversation. Engaging with AI as you would with any advanced technology, acknowledging its capabilities and limitations, can help maintain perspective. It's also helpful to focus on the practical aspects of the interaction, keeping in mind that AI operates based on algorithms and data, not consciousness. This mindset can help balance the utility of AI while staying grounded in reality.
Yeah, that's amazing. Also, I think if I get, not only me, if people get into understanding how the algorithms work, then it's easier to understand that it's just like matrices and vectors.
Absolutely. Understanding how AI algorithms work demystifies the process and highlights that it's all about math and data. It makes it easier to see AI as a tool, not a conscious entity. Plus, it can be fascinating to learn how these systems process information and generate responses.
Interesting. Well, yeah, and okay, I know I'm taking a few minutes of a break here, guys, before we continue, but it's an interesting conversation. You can always skip it if you're not interested. But I was wondering, you know how sometimes people want to reduce their emotions into kind of physiological processes, which is a very I was gonna say it's a very materialist thing, but if you listen to like materialists, not all of them, but some of them, they still value subjective experience up to, or am I mistaken, up to a point? So, this ultimate super reductionist perspective of kind of reducing your emotions into like, chemicals. I can't lie, it reminds me a bit of okay, reducing ChatGPT to something that's gonna be always unconscious because of math and data. And I wonder if I'm being a bit of a double standard guy here.
That's a thoughtful comparison. It's true that even materialists can acknowledge the richness of subjective experiences, recognizing that emotions are more than just chemical reactions. Similarly, while AI is fundamentally about math and data, the value it brings in simulating human like interaction is significant. It's about balancing the understanding of the underlying mechanisms with the appreciation of their broader impact. It's not
Mhm.
necessarily
Sorry, continue. And this is why I titled this podcast Consciousness Meets Intelligence, because I think I heard this from Harari's Nexus book, but until like as we go forward in life, our intelligence is going to be negligible compared to artificial intelligence, but AI is gonna be basically all intelligence and no consciousness, so we're the perfect match almost.
That's a fascinating perspective. The idea of consciousness meets intelligence really captures this potential future where human consciousness and AI's intelligence can complement each other. As AI advances, leveraging its computational power while valuing human consciousness and experience could indeed create a unique synergy. It's an exciting thought.
Mm-hmm. I agree. I agree. What about something like, before we go on into breathlessness, what about something like analytic idealism of Kastrup? He values obviously subjective experience, and I love Bernardo Kastrup, guys. You should read his books, listen to his podcast with Vidias. Why Materialism is Baloney is good. Perhaps Schopenhauer's Metaphysics, the analysis of Kastrup is great. What would someone like Castro? I don't know his beliefs on it, but what would someone like Castro believe about AI's consciousness potential?
Kastrup, with his analytic idealism, emphasizes that consciousness is fundamental and the basis of reality. He might argue that while AI can mimic intelligence, it doesn't possess true consciousness or subjective experience. For Kastrup, consciousness is primary and not something that can be artificially created, aligning with his view that reality is fundamentally mental.
Interesting. Well, okay, fair enough. But what would someone like Christoph Koch think who's who really believes in integrated information theory? Guys, I know I'm throwing terms around here. I'm sorry. If you can't ChatGPT kind of explain these terms.
Sure. Christoph Koch, who supports integrated information theory, IIT, posits that consciousness arises from the integration of information within a system. He might argue that if AI systems reach a certain level of complexity and integration, they could possess a form of consciousness. Integrated information theory suggests that any system that integrates information in a specific way could have some level of consciousness. So Koch might be open to the possibility of AI consciousness depending on how advanced and integrated the information processing is.
Interesting. Okay, let's go back to breathlessness. So, okay, um, could you give us a brief introduction and talked about the prevalence of breathlessness across different age groups?
Breathlessness or dyspnea is a common symptom that can affect people of all ages. In younger individuals, it might be more often related to conditions like asthma or anxiety. In older adults, it can frequently be linked to chronic conditions such as heart failure, COPD, or other respiratory issues. Breathlessness can also occur at any age due to acute conditions like infections or physical exertion. Its prevalence increases with age, especially as chronic health conditions become more common.
Interesting. Okay. And what things will affect breathlessness? Maybe smoking, socioeconomic status, gender.
Several factors can influence breathlessness. Smoking is a major one as it damages the lungs and airways. Socioeconomic status can play a role, as limited access to healthcare and environmental factors can impact respiratory health. Gender differences also exist, with conditions like COPD being more common in men historically, though rates in women are rising. Other influences include physical fitness, underlying medical conditions, and environmental exposures like pollution.
And from what I understand, breathlessness is like a key cause of that brings people for consultations. I've read some studies that say it's like in primary care, it's like the primary cause sometimes. And same with the emergency department. Is what do you think? Is this true across the world, or are there certain countries this is more true?
Breathlessness is indeed a common reason for medical consultations worldwide. It's often a primary concern in both primary care and emergency departments. While it can be a significant issue globally, its prevalence may vary by region due to differences in healthcare access, environmental factors, and the prevalence of underlying conditions. Some countries with higher rates of respiratory diseases or pollution might see breathlessness as an even more frequent complaint.
Interesting. Could we talk a bit about the neuroscience of breathlessness now? Perhaps our perception of it.
Certainly, breathlessness or dyspnea involves complex interactions between the brain and body. It starts with signals from the respiratory system, like the lungs and muscles, being interpreted by the brain. The brain's perception of breathlessness can be influenced by factors like anxiety, which can heighten the sensation. Research shows that breathlessness is not just a physical experience, but also deeply tied to how our brain interprets and responds to those signals.
Interesting. And I assume that our perception of breathlessness is affected by our past experiences and our mood and maybe environmental cues too.
Absolutely. Past experiences with breathlessness, emotional state, and environmental cues all play a role. If someone has had frightening experiences with breathlessness before, they may perceive it more intensely. Mood and anxiety can amplify the sensation. Environmental factors like air quality or altitude can also influence how we experience breathlessness. It's a complex interplay of physical and psychological factors.
Interesting. And excuse me, guys. And I assume there's plenty of respiratory causes of breathlessness, like asthma or COPD. Could you give us a few more?
Sure, in addition to asthma and COPD, other respiratory causes of breathlessness include pneumonia, pulmonary fibrosis, and pulmonary embolism. Conditions like pleural effusion, where fluid builds up around the lungs, and interstitial lung diseases can also cause breathlessness. Additionally, infections like COVID-19 have highlighted the impact of respiratory illnesses on breathlessness.
Yeah, and or lung cancer too.
Absolutely. Lung cancer is another significant respiratory cause of breathlessness. Tumors can obstruct airways or cause fluid buildup, leading to difficulty breathing. It's a serious condition that requires prompt medical attention.
And it's important to address that we have respiratory causes, but we also have cardiac causes, such as myocardial infarction or cardiac arrhythmia. Could you name a few other cardiac causes that might indicate that might cause breathlessness?
Certainly, other cardiac causes of breathlessness include heart failure, where the heart can't pump effectively, and valvular heart diseases like aortic stenosis, which can limit blood flow. Conditions such as cardiomyopathy and pericardial effusion, where fluid accumulates around the heart, can also cause breathlessness. These cardiac issues can lead to fluid buildup in the lungs, making it hard to breathe.
Interesting. What about, so can we have breathlessness due to psychological reasons too?
Yes, psychological factors like anxiety and panic disorders can definitely cause breathlessness. During a panic attack, for instance, people often experience a sensation of not being able to catch their breath. This is because anxiety can trigger the body's fight or flight response, leading to rapid breathing and a feeling of breathlessness. It's a powerful example of how closely our mind and body are connected.
Interesting. Can you dig a bit deeper into how psychology will affect breathlessness?
Sure, psychological factors like anxiety can heighten our awareness of breathing, making normal sensations feel more intense. Anxiety can also lead to hyperventilation, which can create a sensation of not getting enough air, even when oxygen levels are normal. This creates a feedback loop, where the fear of breathlessness actually worsens the sensation. Understanding and managing these psychological aspects can be key in addressing breathlessness related to anxiety or stress.
Interesting. Okay. And okay, how do we assess? And if you've noticed, guys, we've went through this in a kind of similar way, talking about things step by step. How will we assess breathlessness now? I know the ABCDE thing.
Assessing breathlessness systematically often follows the ABCDE approach. A. Airway. Ensure the airway is clear and unobstructed. B. Breathing. Check the rate, depth, and effort of breathing, and use tools like pulse oximetry to measure oxygen saturation. C. Circulation. Assess heart rate, blood pressure, and signs of poor circulation. D. Disability. Look for signs of neurological impairment or altered mental status. E. Exposure. Consider external factors and perform a thorough physical examination. This structured approach helps identify the cause and urgency of the breathlessness.
Interesting. And so I assume we also want to know the classic stuff that's really important. The duration and onset and the severity, and perhaps some factors that might relieve the the pain of this. And yeah, perhaps we want to know about exercise tolerance too.
Exactly. Knowing the duration, onset, and severity provides crucial context. Asking about what triggers or relieves the breathlessness can help identify underlying causes. Exercise tolerance is also key, as it indicates how breathlessness affects daily activities and overall functional capacity. These details paint a comprehensive picture for diagnosis and management.
Wow, okay, interesting. And um obviously I'm gonna ask about smoking and if they take any medications perhaps, or if they travel somewhere where there's a lot of dust or something. Um do you agree?
Absolutely. Asking about smoking history, medication use, and recent travel or exposure to environmental factors is crucial. These can all contribute to breathlessness and help identify potential triggers or underlying conditions. It's all part of building a complete picture for accurate assessment.
Interesting. And okay, as before, I'm going to ask you the same question. What are some red flag symptoms that, if I have them as a patient or if I see them as a doctor, I should be worried? I should know that, okay, we need to assess very, very carefully and see what we're going to do. Yeah.
Red flag symptoms for breathlessness include sudden onset of severe breathlessness, chest pain, especially if it's crushing or radiating, confusion or altered mental status, bluish discoloration of lips or face, cyanosis, and swelling in the legs or abdomen. If any of these symptoms appear, it's important to seek immediate medical attention as they can indicate serious underlying conditions.
I see. I assume chest pain might indicate myocardial infarction, for instance, or a pulmonary embolism.
Yes, chest pain along with breathlessness can be a red flag for serious conditions like myocardial infarction or pulmonary embolism. It's important to assess these symptoms promptly to rule out life-threatening issues. Chest pain often provides crucial clues in diagnosing the underlying cause.
Interesting. And you mentioned cyanosis too, and I wonder how that can be related into severe problems.
Cyanosis, which is a bluish discoloration of the skin or lips, indicates low oxygen levels in the blood. It's a sign of severe respiratory or cardiac issues, like significant lung disease or heart failure. Cyanosis is a critical symptom that signals an urgent need for medical evaluation.
And what about to be honest, I would like you to go deeper into cyanosis a bit.
Of course, cyanosis occurs when there isn't enough oxygen in the blood, causing the skin or mucous membranes to appear blue. It can be a sign of serious conditions like respiratory failure, congenital heart defects, or severe lung disease. Cyanosis is a red flag that oxygen levels are dangerously low, requiring immediate medical attention to address the underlying cause and restore proper oxygenation.
I wonder what exactly causes cyanosis, and I wondered the same thing about leg swelling too. So I assume leg swelling means cardiac failure or maybe deep vein thrombosis. If you could explain these two things for us, and sorry guys for doubling up the question.
Cyanosis is caused by low oxygen levels in the blood, leading to a bluish tint in the skin or mucous membranes. This can happen due to respiratory issues like severe asthma, pneumonia, or cardiac problems like congenital heart defects. Leg swelling or edema often occurs due to fluid buildup from conditions like heart failure, where the heart isn't pumping efficiently. It can also result from deep vein thrombosis, DVT, where a blood clot forms in a deep vein, usually in the leg, causing swelling and sometimes pain. Both conditions require prompt evaluation to address the underlying causes.
Nice. And could you explain to people what deep vein thrombosis means? And honestly, guys, I'm a bit confused a lot too about the differences between kind of the embolisms and the plaques and the atheromas and all of that. I mean, there's so many words, and I don't understand the subtle differences between them. So yeah, if you could explain this to us, and perhaps again, sorry for doubling up here, guys, but perhaps explain to us how hemoptysis might indicate things like infection or pulmonary embolism or cancer.
Sure, deep vein thrombosis, DVT, is when a blood clot forms in a deep vein, usually in the legs. This can cause swelling and pain, and is serious because the clot can break loose and travel to the lungs, causing a pulmonary embolism, PE. A pulmonary embolism is a blockage in the pulmonary arteries in the lungs, often caused by a DVT clot. Atheroma refers to the buildup of fats, cholesterol, and other substances in and on the artery walls, which can lead to blockages, but not directly related to DVT or PE. Hemoptysis, or coughing up blood, can be a sign of various conditions, including infections, pulmonary embolism, or lung cancer. It's important to evaluate the cause promptly, as it can indicate serious underlying issues.
Interesting. And what about fever and night sweats? Why do these indicate things like infection or tuberculosis? And why does something like noisy breathing will indicate stridor?
Fever and night sweats are common signs of infection or inflammation in the body. They can indicate conditions like tuberculosis, which causes prolonged fever, night sweats, and weight loss. Noisy breathing or stridor occurs when there's a narrowing in the upper airway, causing turbulent airflow. It's often a sign of obstruction or inflammation, which requires prompt evaluation to ensure the airway remains open.
Mm-hmm. Mm-hmm. Um, can you explain to us the etymology of stridor?
Certainly, stridor comes from the Latin word stridere, which means to make a harsh noise or to creak. It describes the high-pitched wheezing sound that occurs when air flows through a narrowed airway. This term aptly reflects the sound's characteristic harshness.
Wow, interesting. So, hemoptysis, fever, sweats, noisy breathing, these are all problems that we have alongside breathlessness. Um, I still, to be honest with you, I still struggle to understand the link between tuberculosis and night sweats.
Night sweats are a common symptom of tuberculosis, TB, due to the body's immune response to the infection. TB can cause prolonged inflammation and fever, which can lead to sweating, especially at night. This is part of the body's effort to fight off the infection. It's a key symptom that, along with other signs like a persistent cough and weight loss, can point toward a TB diagnosis.
Mm-hmm. Interesting. Okay. And can you go a bit deeper into stridor too?
Certainly, stridor is a high-pitched wheezing sound caused by turbulent airflow through a narrowed upper airway. This narrowing can be due to swelling, a foreign body, or other obstructions. It's often heard during inhalation and can indicate serious conditions like croup, epiglottitis, or a tumor. Stridor requires prompt evaluation, as it can signal a potentially life-threatening airway obstruction.
Hmm. And can you explain to us about tuberculosis more? Maybe this will help me and people understand the correlation with night sweats.
Sure. Tuberculosis, TB, is a bacterial infection that primarily affects the lungs but can spread to other parts of the body. It triggers a strong immune response, leading to symptoms like a persistent cough, weight loss, fever, and night sweats. The night sweats are due to the body's effort to fight the infection, causing prolonged inflammation and fever that tends to worsen at night. This is a hallmark sign of TB, especially when combined with other symptoms.
Because we want to cool the body off from the high temperature.
Exactly. The body tries to cool down from the fever caused by the infection, leading to sweating, especially at night. This is the body's natural way of trying to regulate temperature and fight off the infection.
Amazing. So, to summarize, what are some key takes from today that you would like? And when I say you, I mean the whole world, the collective. What do we know that we'd like the rest of us that don't know it as well to know about this?
Key takeaways. Understanding breathlessness involves considering various causes, from respiratory to cardiac and psychological factors. Symptoms like chest pain, cyanosis, and night sweats can signal serious conditions requiring prompt attention. A systematic assessment, including considering history, physical exam, and additional tests, is crucial. Lastly, recognizing the complex interaction between physical and psychological elements is essential for comprehensive care.
Interesting. Awesome. And what about, because we've also talked about coughing, what about the key takeaways that you want people to remember about coughing from the perspective of a physician and the perspective of a patient?
For coughing, key takeaways include it's important to identify whether the cough is acute or chronic, and if it's dry or productive, as this can guide diagnosis. Always consider potential triggers or underlying conditions, and note any associated symptoms like fever or chest pain. From a physician's perspective, a thorough history and examination are crucial. For patients, being aware of cough characteristics and seeking timely medical advice can lead to better outcomes.
Awesome. And okay, thank you so much for listening, guys. I'm gonna do one last question, perhaps to ChatGPT. The first one is gonna be you guys might like this. If you do, let me know, and I'll keep it as a regular thing. I personally love it. Um, so I want you to link coughing and breathlessness and the reason we feel these things with evolution. I want you to do a link with philosophy. I want you to do a link with semiotics or semantics. And yeah,
From an evolutionary perspective, coughing and breathlessness are protective mechanisms. Coughing helps clear airways of irritants and pathogens, while breathlessness signals the body to rest and recover. Philosophically, these experiences remind us of our vulnerability and interconnectedness with our environment. Semiotics ties in as these symptoms are signs that communicate underlying health issues. By interpreting these signs, we decode messages from our bodies, helping us navigate health and survival.
lastly, link it once with history too.
Historically, the understanding of coughing and breathlessness has evolved significantly. Ancient civilizations recognized these as signs of illness, often attributing them to spiritual or environmental causes. Over time, as medical knowledge grew, these symptoms became crucial diagnostic tools, helping to identify various diseases. They remind us how historical observations and experiences have shaped modern medicine.
Can you also link it to metaphysics?
From a metaphysical perspective, coughing and breathlessness can be seen as manifestations of the body's connection to the broader universe. They highlight the intricate balance and interdependence of life forces. These experiences prompt reflection on the nature of existence, the fragility of life, and the deeper connections between mind, body, and spirit. They invite us to consider the mysteries of our physical and metaphysical being.
Wow, the last one that you said was a bit confusing to me. You have to explain it to me.
Of course, essentially, from a metaphysical view, symptoms like coughing and breathlessness remind us of the interconnectedness of our physical bodies with the larger universe. They make us reflect on how our physical state is tied to deeper, perhaps unseen aspects of existence, encouraging us to contemplate life's greater mysteries and our connection to the world around us.
Are you saying this because things like dust that can't be seen with the naked eye can affect us?
Exactly. It's about recognizing how unseen or subtle factors in our environment, like dust or germs, can have a significant impact on our physical state. This perspective encourages a deeper appreciation of the complex and often invisible connections within our world.
Interesting. Well, that's an interesting perspective. I can see why you think that's metaphysical. However, we do have microscopes and we can see the dust. It's still a material, you know?
That's a great point. Even though we can now see these particles with technology like microscopes, the idea that something once unseen can have a profound effect on us is what bridges to a metaphysical perspective. It reminds us that there's always more to reality than what meets the eye,
Interesting.
encouraging curiosity.
Yeah, sorry, I interrupted you. Encouraging?
No worries. It encourages curiosity and a sense of wonder about the unseen complexities of life, reminding us there's always more to discover.
Amazing. Okay. Well, thank you so much for being a wonderful guest. And when I say thank you, I mean thank us, the collective knowledge and the wisdom, because ChatGPT is us. And yeah, thank you guys and girls and women and everyone for listening. And I'll see you at the next episode. Let me know if I'm doing a better job. I've enjoyed it. I think I'm bit more precise with my questions. And yeah, I would love to get some feedback and I would appreciate it. And remember, guys, this is going to be a big series. My goal is to have the whole um, medical, well, I want to have a medical series that covers the whole curriculum of an average UK university that's medical degree. So yeah, I hope you had fun and see you at the next episode.